This echo case is about a 38-year-old patient who, 1 week ago, had a viral infection with fever and for a few days now has been experiencing progressive dyspnea on exertion despite an improvement in the symptoms of the flu-like infection. Let's take a look at this echo clip first. You've probably already noticed that a peristernal long-axis view is shown here. We see the left ventricle with the septum and the posterior wall. Here's the mitral valve and the left atrium. We can just make out the aortic valve. This is where it exits into the aorta. And here at the top of the image is the right ventricular outflow tract, RVOT. And I think what is immediately apparent is a large pericardial effusion that extends posteriorly, especially behind the posterior wall. If we look at the scale over here, the extent of the pericardial effusion is perhaps 3 centimeters. And here, too, above the RVOT, we see a pericardial effusion located anteriorly. Here it is significantly smaller than posteriorly, perhaps, I think, a maximum of 1 centimeter in diastole. We always have to measure the extension of the effusion at the maximum filling of the ventricle, i.e. in diastole. But this is clearly a very large, significant pericardial effusion. Whether it is hemodynamically relevant cannot be definitely assessed from this clip. I think we still have a good contraction and relaxation of the walls and sufficient filling of the cavity. Up here, the wall seems to be moving a little unnaturally and wobbling a little in the effusion. So we need to look at more images to assess the hemodynamic significance. One more small finding, what stands out here is the fat pad in the atrioventricular groove. It is typical that this structure, which is otherwise not very visible, can be seen very clearly in effusions. Let's look at the left ventricle more quantitatively. What kind of image is this? Of course, an M-mode. The M-mode is placed through the septum and the posterior wall, and in the middle here, that is, of course, the LV cavity. This corresponds to the septum, the cavity, and the posterior wall here. And here, at the top, you can see the RVOT area, which is the area above here. Now, measured in diastole, here at the maximum expansion of the ventricle, we can see that the pericardial effusion measures about 3.2 centimeters. So in terms of size, it is a large pericardial effusion. The black area at the back is the pericardial effusion. Behind it, you can see artifacts of the lung. Let's now take another look at the movement of the ventricle. Here's the posterior wall, here's the septum. If we look at the peak of the contraction or the time of contraction, of the maximum contraction, then the septum is a tiny bit later. And you can see that the RVOT is at least as late, if not even later. So we are dealing here with a certain degree of intra- and interventricular dysynchrony, which is most likely caused by the effusion in this young patient with no known coronary artery disease. Next, let's take a general look at the morphology of the left ventricle. We can see here, and then in the measurement at the top that the wall thicknesses are normal. So the ventricle is not hypertrophied. This is a male patient, so wall thicknesses of up to 10 millimeters are normal. Normally, the septum is somewhat thicker than the posterior wall, for example in patients with hypertension. But I think you can also see that the lines, the edges, are very difficult to follow here, and therefore the deviation between the septum and the posterior wall is more likely to be a measurement variance. Let's look at the LV cavity. We can see from the values here that the left ventricular and diastolic diameter, LVEDD, is 38 millimeters, and the end systolic diameter is 22 millimeters. So I think there is still an acceptable degree of expansion in diastole. I would even consider the variance to be fairly normal. This suggests that the left ventricle is not yet severely compromised hemodynamically. Okay, next clip. We are here at the short axis. We see the left ventricle here. It is almost at the mitral valve level, but has already slid towards the papillary muscle. So it is not a perfectly adjusted position. And up here, we have the right ventricle. Here we see the transverse moderator band. And again, we see a small pericardial effusion here at the top. And this effusion, which is about 2.5 to 3 centimeters in size, here at the bottom. What is noticeable in this image is that the heart is already swinging a little bit in the short axis. I can't say that the effusion is really severely impairing the filling of the left ventricle or the contraction of the left ventricle to the extent that we would have a complete tamponade here. That's not the case, but the whole heart is swinging a little bit, I think. Okay, let's look at the next image, the four-chamber view. We can see that the left ventricular function is actually still quite good. The F is certainly okay as well. And when we look at the right ventricle, we also have the feeling that at least the longitudinal function is still quite well preserved. We have a larger effusion laterally, then a little less effusion upwards, and a little more here on the side. Of course, this is always a bit optically deceptive due to the curtain of reverberation artifacts, as I call it, coming in here. We don't see the free wall of the right ventricle as well as we might visually imagine. Overall, the heart seems to be moving a little bit here as well. We can still see the strongest attachment down here, since there is very little effusion here near the left atrium. It seems to be moving more up here, but don't be deceived by that either. It may seem a bit more pronounced here due to the reverberation curtain than it really is. So now I would like to draw your attention to the right atrium. You can see here that the right atrial free wall moves a bit like a lasso, or it's comparable to a jumping rope when one person stands in the middle and two move the rope. Alright, and something obviously seems to be happening here. I'll pause the clip now. So now that I've paused it, I move back and forth a bit and you take another look at the ventricles. We are now in systole. So I go back here again. You can see that the ventricles contract at the top. When the ventricles contract, the atriums should actually be maximally filled or dilated. But you can see that the lateral wall is dented here. I go back and forth again, and you should pay close attention to this finding. You can see here how the effusion causes the wall to bulge inwards. And then when the systole is almost over, the right atrial wall expands downwards again. So in ventricular systole, or in other words, in the diastole of the atrium, only half of the atrium or something around that is actually available, if at all, to fill. So here there is clearly a compromise of the inflow into the right atrium. That means that it is already beginning to be hemodynamically relevant. In this four-chamber view, which was taken a little later, about 30 seconds or so, you can see a little more of this swinging heart. This gives us a little more of this impression. But of course, you also have to bear in mind that the probe handling is not so easy in this case. Rather, with so much dynamics, we certainly come out of the axis a little bit. We also know this phenomenon from foreshortening when we want to determine the EF of the left ventricle. So you always have to be a bit careful whether it's really that extreme here or not. But I would say that at least we get a sense that there is a certain amount of swinging heart here. However, when we look at the F, it's okay. We calculated the F as normal, and if you now look at the four-chamber view quantification. Okay, please always do the EF calculation biplane, of course. Then the EF is quite good. The ventricle with a volume of 84 milliliters is certainly at the lower limit for an adult man. And what is left over to even get 60 milliliters of stroke volume is no longer that much at the end of systole. But because the heart rate of 108 per minute is higher than normal, we then have a relatively okay cardiac output and also a stroke volume overall that is still reasonably okay. But the patient is no longer achieving 35 milliliters per square meter stroke volume. So maybe that's another small indication that this could have a certain hemodynamic component. What else do you do when you want to evaluate hemodynamic components in a case of a tamponade? Well, of course, the Doppler profiles. And here we see the Doppler profile over the mitral valve, the pw-Doppler. You can see small fluctuations in the peak values. This is what we need to pay attention to. However, I would say that there is not an awful lot here. The diastole itself doesn't appear to be significantly altered. We have a normal E to A ratio here with an okay E that isn't overshooting either, and the deceleration time is normal too. And even when we look at the LVOT, we see a certain variance here, yes, but it's not huge. So finally, let's go back to the four-chamber view, and now we've tried something else. What I'm going to show you now is only approximately correct, but it's fine to do it to get at least an approximation. You can try to determine the volume of the pericardial effusion. And to do that, we simply did the following. We sort of had an inner sphere here and an outer sphere. You can see it down here. It's not quite right, but it's close. And then we simply traced around all the heart cavities our inner sphere and the effusion area our outer sphere. And if you subtract the two from each other, you can at least approximately determine the amount of effusion. For this, we used a trick, namely the calculation of the ejection fraction. We assumed the outer volume to be the end diastolic volume and then traced the inner volume as the end systolic volume. The ultrasound machine then subtracts the two values from each other and calculates a fictitious stroke volume. Of course, this is anything but the stroke volume, but of course, it's the effusion. But this is how you can do it approximately. So we tricked the computer a little and voila, we got 960 milliliters, almost a liter. Of course, you shouldn't pay attention to the cardiac output here, that would be a bit much. So about a liter as the amount of pericardial effusion. And indeed, the patient then came to the hospital and was actually punctured there. And a liter was drawn out. So a liter was punctured, not bad at all, a good guess. Our referral diagnosis was exudative pericarditis due to a viral infection that the patient had suffered from a few days earlier, and then subsequently developed this pericardial effusion. The referral was made on the suspicion of an incipient tamponade, i.e. an incipient hemodynamically relevant pericardial effusion, particularly affecting the right atrium. Why only incipient? Well, the left ventricle and the right ventricle were not yet severely compromised, although the slightly reduced left ventricular volume and the findings I demonstrated to you indicate a kind of a problem. What clearly spoke in favor of the admission, however, is that, of course, the clinic is always leading and a diagnosis of tamponade is ultimately a clinical diagnosis. The patient had dyspnea and increased resting heart rate, and therefore immediate admission to the hospital was carried out, where the patient was then punctured, as I told you. Thank you for following this case to the end. We would really appreciate if you may leave a like or subscribe. Take care and see you soon.